Hello and welcome everyone to Queen's Global Oncology Program rounds. We used to have these rounds every Wednesdays in the past, and we had taken a short break. So it's very good to resume this program with none other than Dr. Ophira Ginsburg today. Some of you may know that Dr. Ginsburg is actually an alumnus of our Queen's University. She has been a medical student here in the past and has been a faculty. She started her faculty career in oncology from Queen's University in the past. And I consider Ophira as my sister. And, she has been a mentor to me in the field of global oncology. And I have learned a lot from her. So it's especially a big privilege and honor for me to welcome her back to her own mother institution, as me now being a part of that mother institution, to welcome Dr. Ginsburg back to Queen's University today for Queen's Global Oncology Rounds. And also FYI, Dr. Ginsburg will be giving us grand rounds tomorrow morning at 8 a.m. in the same venue. So you're welcome to join tomorrow morning's
different talk.
Grand rounds as well. The talk will be different. The talk will not be the same. Today, she's going to speak about the role of the US NCI Center for Global Health. For those of you who do not know, Dr. Ginsburg is Senior Advisor for Clinical Research at the Center for Global Health at the National Cancer Institute in US. And she's also currently co-chair of the Lancet Commission on Women and Cancer. Today's talk will be about the role of NCI Center for Global Health, and tomorrow's talk will be about women and cancer. And as her brief bio, she has previously worked at the WHO, IARC, at University of Toronto and NYU. And I think most of the audience that has joined us today already know about the depth and the breadth and the quality of the work that Dr. Ginsburg has done in the field of global oncology. So without much ado, let's give her a warm welcome. And let's learn about what the role of the NCI Center for Global Health is in the field of global oncology, and how probably we can join those efforts and how we can also contribute to it and be a part of it. Thank you.
Thank you so much. I think actually I have the wire microphone here, so perhaps I'll give you this back. Yeah, we can turn this one off. I just want to make sure that people can hear me who are online. Maybe we can't see you, but somebody can unmute and say, hey.
Yes, I can hear you well. Yeah.
Wonderful. Thank you so much. And thanks, Vishal, for that lovely introduction. Not only am I an alumna from medical school, but I actually did my undergraduate biology degree here, which I'm afraid to say is almost 40 years ago, I think, when I started. So let me just get the slides going. I have the privilege to present today about the US NCI Center for Global Health. Just having trouble advancing the slides. There we go. You can see here, Dr. Monica Bertagnoli is our first ever woman director of the US National Cancer Institute. And if you look down to where you see my boss and our director, Dr. Satish Gopal, who is our head of the Global Oncology Program, we actually sit as a center within the office of the director, just to give you a sense of where we're at. Now, the US NCI, there's an echo. Okay, why is there an echo? Is this microphone on or off?
Oh, I think
off. You think it's okay now? All right. The US NCI was founded actually in 1937, but in its current form, it was founded by the National Cancer Act of 1971. And you can see here, we lead, conduct, support cancer research across the nation and actually globally to advance scientific knowledge and help all people live longer, healthier lives. That is the mission of the NCI. We have an annual budget of $6.9 billion. And for my Canadian colleagues and friends, that's not a mistake, that's $billion. So we are the largest funder of cancer research in the world, but it's not only a recent phenomenon that the NCI has taken an interest in global dimensions. And in fact, global health was mentioned in the original founding act. And the reason for this is because, well, we all kind of can think about examples, those of us who are working cancer research, of scientific discoveries that really happened because of global collaborations or because of our learnings from people doing research in low income and middle income country settings all around the world. There's a few examples here just to show you some geographic pathology mapping in 1968 on liver and biliary tract disease, and research as early as 1985 on dietary interventions in Asia. And it's clear that studying rare cancers, for example, a cancer that's rare in Canada but might be more common elsewhere, the AIDS Malignancy Consortium is an example of this kind of effort that has been pivotal in convening together collaborators from countries where HIV remains unfortunately endemic, and we see a lot more malignancies like Kaposi sarcoma, for example, that are relatively rare cancers here. So there's a lot we can learn. Fostering innovation with efficiency and less encumbrance by policy and practice conventions. I struggle with this one. I think this is an interesting way of considering how we can become more efficient by learning about the efficiencies elsewhere. And I could maybe make a comment about the Tata Memorial Cancer Center being one such place that does high quality research and excellent care, but on a magnitude, a scale that is just, would make our heads spin here, even though we are, many of us, busy clinicians. We have a strategic plan that is started in 2021. I'm going to tell you a little bit about it and then give you some examples of the research highlights, research training, and our role in partnerships and dissemination, which could be, I hope, of interest here to those of you here at Queen's University and calling in from elsewhere throughout Canada to consider potential opportunities to collaborate with us. So in 2021, this was sort of relaunched under the leadership of Dr. Satish Gopal, who wrote this very nice viewpoint in JAMA. I highly recommend reading it because it so nicely articulates what our mission and values are and how we fit within the NCI's mandate, in this case, to fulfill President Biden's exhortation to end cancer as we know it, which is, of course, part of the phrasing for the Cancer Moonshot program that I'm sure everybody's aware of. A little bit about our strategic plan now, and these are the four key areas. Our intramural global portfolio of funded research in 2021 is on this diagram, only to show you the extent to which of that, 6.9 billion in total. Foreign component awards represent almost 13%. And by foreign component, that includes Canada. Okay, I'm mentioning this for a reason, not just because I'm here in Canada right now, but because Canadian researchers actually are very successful in competitive grants from the NCI. So foreign doesn't necessarily mean low and middle income countries, of course, but most of these are indirect awards that first go to a PI in the United States, and then there might be a subcontract, for example, with co-PIs, et cetera, colleagues elsewhere. Whereas the direct international awards represent a very small part of the portfolio at just 0.6%. This hasn't changed much over time, and it's something that we'd like to see improve as we, I hope, make our case why global health and global oncology research is more important now than ever to really tackle the challenges that we all are faced with, mounting, obviously, numbers of people with living and dying from cancer, and the escalating costs of cancer medicines. I'm here at Queen's University, which is the hub, really, in a way, for thought leadership in that domain, with people like Dr. Vishal Gyawali and Dr. Chris Booth, et cetera, looking at the policies and the impact to countries of medications that are still on patent and really unaffordable in many settings. The extramural global portfolio, just to give you a sense of what kind of research that we fund. This is over a 10-year period. And you can see it's not that bad in terms of distribution of the different types of research. These are sort of standard classifications from biology, treatment, early detection, causation, prevention, and cancer control. This is all together, not just for the research dollars that are going towards global work. On the right panel here, you can see the percent of international awards by disease site, by site group. And in fact, cervical cancer, I don't show this slide, but if we focused only on the funding that's gone towards research in low-income and middle-income countries funded by the NCI, you'll see that cervical cancer features very prominently for good reasons. You know, it's unfortunately remains the #1 cause of cancer-related death among women in over 40 countries, many of which are in sub-Saharan Africa, where HIV is endemic. And so matching the resources to where the need is greatest is something that we really challenge ourselves to do, as you do here as well, of course, in Canada. This is just, it's a busy slide, but just to give you a sense of the extramural global portfolio of research over the last 10 years. And I'd like to draw your attention to the middle here with the individual countries. I don't think you can see the pointer. No, you can't. So the middle shows individual countries, and Canada ranks the highest in terms of countries outside the US that have received, that have been awarded grants, mostly as indirect awards. Then you can see the UK, Germany, and China is in the top 5, China being a middle-income country. And so you get a sense of the breakdown from the countries where we provide funding. And on the right-hand panel, the individual low and middle-income countries, you can see where China fits in with the rest. It's far and away, you know, the country with the most awards that have been granted in that 10-year period. South Africa comes in next, Uganda, and then India, Kenya, Nigeria, et cetera, down the line. So although we sometimes feel there's a perception that most of the grants that are in low and middle income countries, whether indirect or direct, are in on the African continent. In fact, there's a lot of our awardees that are in other regions of the world, in particular in Latin America as well. Focusing in on the research with a few examples of some of the highlights, let's say, at the top. These are our 5 sort of strategic priorities in research. The first, not in any real order, but the first on the screen is to accelerate technology development for global cancer control. The second being accelerating global cancer implementation science. I'm going to speak about those in a little bit of detail. The third, understand and address global cancer health disparities. A little word here just to say, when we talk about disparities, cancer health disparities in the US, in colloquial terms, that's often seems to be equivalent to domestic, to the US situation when we use the word disparities. And when we talk about cancer inequities, we're talking about between countries. But it's a funny kind of convention, in fact. And we're, again, challenging ourselves to think outside the box and to be more holistic, because global health really is all of us, right? It's not the US and Canada versus people in low and middle income countries. Global health is health, right? And so cancer health disparities exist in every country, including, of course, in Canada. Looking at the science of cancer health disparities is something that is being done in a big way in Canada as well as the US, but taking some of the learnings, some of the methodologies, and some of the outputs, which a lot of it is behavioral research and implementation science, and health services research, which is also a lot of what happens here, can be adapted to other settings. So I would consider this very much also a domestic program. But for the purposes of the NCI Center for Global Health, we are trying to focus all of this research on low-income and middle-income countries. And finally is understanding cancer etiology. And so one of the roles of the Center for Global Health isn't just to provide, potential funding and training opportunities for colleagues working in low and middle income country settings, whether they're based in the US or elsewhere, but is also to help convene and coordinate some of the global health activities in research and also training for the NCI as a whole. So I'm going to show you just one of the programs that's been we think very successful, and we've just had the second round of awardees in a U01 mechanism. And I'm not sure how many people here would be familiar with the types of grants that the NIH has, the types of research grants, but the U designation means it's a cooperative grant. It's the kind of grant that when several are usually awarded at the same time, we consider that as an opportunity for the PIs, co-PIs, et cetera, within those within that grant to be potential collaborators with each other, right? And so I'm going to get to this a bit later when I talk about a program called the D43. Actually, we just changed the name to something catchier, but the D43, which is a cooperative mechanism for mentored research training, right? Where we're creating what we'd like to consider a community of practice. But anyway, back to the new affordable cancer technologies. You can see here, there are some interesting projects that may be a little hard to, well, you should be able to read it on your screen if you're and in the room as well. Yeah. So development and validation of artificial intelligence enabled portable colposcopy is one such program. You can see there's a couple of programs around AI. There's radiotherapy treatment for cervical, head and neck cancer, et cetera, et cetera. There's been quite a few very exciting projects that are already well in the pipeline of development that started as an earlier version of this ACT, or Affordable Cancer Technologies program. Here's one in the left panel that is all about thermocoagulation. For those of you who don't know, who aren't involved in cervical cancer, this has been in some ways a game changer, or potentially will be a game changer, as we're offering the opportunity for treatment of precancerous lesions in a way that's much more practical than the previous big tanks for cryo therapy that unfortunately just have not been scalable in most countries where it's needed. Thermocoagulation, there's been a few devices that are, handheld and can be done almost door to door or in rural areas with appropriate training, and they're well tolerated, et cetera. On the right-hand panel, you can see another project on household air pollution biomarkers, just to give you a sample of those projects. And I'm happy to make the slides available so you can look up those projects that have already been partly published anyway. This slide is meant to, I wanted to remind ourselves about the importance of research to practice, right? And this is one of the biggest challenges in global cancer control when it comes to not just new technologies, but the use of already evidence-based technologies that have been within the guidelines, international and national guidelines for some time, why it takes so long to get that new evidence into actual practice where it's needed the most. And you've heard about the translational pipeline of, 17 years. And I've tracked down those papers, and it's hard to, I'd love if somebody can actually model that for global cancer control. There's an idea for a PhD student. But here we see an opportunity to also evolve the science of implementation research, which is the purview of our deputy director, Dr. Patty Gravitt, who's long been a thought leader in implementation research for cervical cancer. I believe she developed this idea, and certainly this slide, taking evidence-based practice and considering it with real-world evidence and adaptation and contextualization and appropriate early community stakeholder engagement to make it practice-based evidence, and it becomes a loop. It becomes a learning loop here. And there's ways to do this in a rapid way through a process called embedded implementation research, or implementation science, I guess, which is also something that Dr. Gravitt and colleagues are working on. Recent highlights in implementation science could be found here with, again, a UO1, sort of a cooperative type award for fiscal year 2022. And this was a special opportunity on HIV and implementation science. And you can see a few of the projects here. There's one that's about the prevention of anal cancer using screen and treat for high-grade squamous intraepithelial lesions. That's for those non-clinicians, that's just to say that anal cancer is not a particularly rare cancer, but it's very common in populations that have high rates of HIV/AIDS. And again, here's an opportunity to learn about best practices that could be adaptable to other settings, including in the US and Canada. Another one on cervical cancer control for HIV-positive women in Nigeria. There's one other one I wanted to highlight, but maybe we'll just move on. Smoking abstinence. Yeah, there's also a whole program of tobacco control related research. That's our branch director for research is Dr. Mark Parascandola, who's done a lot in tobacco research. And there was a recent funding opportunity for specifically tobacco control in HIV positive, in people living with HIV. There's some really interesting projects that have come from that. So this slide is to shift gears a little bit into clinical trials. I'm not going to show you the portfolio analysis because it's important, but it's a little bit on the dry side for a talk like this, just to say that we do recognize that cancer research, we have a long way to go to really help advance useful cancer clinical therapeutic trials in low and middle income country settings. And that's one of the programmatic areas that I'm helping to sort of build for the center. And those of you who I met with when I was here a few weeks ago discussing common sense in oncology, we had a lot of discussion about that. And for those of you who don't know what that is, you soon will. We hope you'll join this new movement to try to get our heads around how best to really serve the needs of most of the world's population through better opportunities in cancer clinical trials. This was a slide from a seminal paper in JAMA Oncology in 2021 that really highlights the problems with, the number of cancer clinical trials published in a certain period of years, how many were done by high income countries, upper middle, lower middle income countries, and you can see 0 were conducted in low income countries. So challenges include, but are not limited to, a poor match to the global cancer burden. So what are the trials focusing on, and do they relate not just globally, but do they relate to the countries of interest? So sidebar, we're often asked, how can we help recruit more participants for clinical trials? Well, period, right? We want to do better in general. How can we do that better in Canada, in the US? How can we also reduce cancer health disparities by improving diversity among those participants in Canada and the US and Australia and everywhere else? All important full stop. What about how can we enroll more patients in middle income and lower middle income countries for our trials that we're doing in the US? That's important as well, right? But it can't be the only thing that we're focused on when we're talking about increasing access to new drugs or access to clinical trials in these settings. And so what we're trying to do now is to take stock of what is most important from the perspective of our colleagues based in Nepal and India and Botswana and Honduras and everywhere else, and get a better sense of, if they could start a clinical trial tomorrow, what would be the priorities for them? If it's all about patient drug access, that is an important consideration. But what if it's also about looking for better ways? Well, through the access question, what about dose modifications? What about different schedules? And that's a huge area now of interest, right, for all of us. Especially as drug costs escalate. I put this slide here just to pay homage to my dear friends here at Queen's University and in Rwanda and elsewhere around the world. You can see Fidel Gumya's first author and Chris Booth's senior author, and where's Bichel? There's Bichel. So this is an important paper that I encourage people to look up. I'm not going to go into detail, but it came after the one I showed you by Wells et al. In JAMA. And there's another one coming soon that I would encourage people to look for, right, in the journal Cancer, Bichel? Yeah, we publish soon. So these are like bibliometric analyses and other and related methods for looking at the landscape and whether the landscape of cancer clinical therapeutic trials in low and middle income settings actually map to the cancer burden, and also do they reflect the health of the cancer research ecosystem, right? Do the outputs make sense? And if they don't, why don't they? There's related work also in authorship, which I won't get into now, but I have personally have an interest in that. I see there's a few things in the chat. I don't know if I should be looking at those, but if there's anything to draw my attention, let me know, please. Thanks. This is an example of really important research that was funded by the NCI that was practice changing. And you can see here in the NCCN, for those of you who practice oncology, these are commonly used guidelines that also have resource stratified and now harmonized guidelines for sub-Saharan Africa, showing you Kaposi sarcoma, and a trial that was, this is not my own clinical area, but I'll do my best to reflect why this was important and why this is courtesy of Dr. Patrick Lair, who I hope many of you know is a dear friend and colleague who's helping us at the Center for Global Health and is previously the head of his own comprehensive cancer center, and also the head of CTAC, which is the external advisory board for the NCI's clinical trials unit. Pat helped really pioneer medical oncology and cancer research in Western Kenya through the EMPATH program. I know that University of Toronto is part of that program. So borrowing his slide, and he borrowed Satish Gopal's slide. So thanks to both of you. Cancer clinical trials in Africa must be appropriately contextualized. I would consider this a really important sort of exemplar paper. This was in the Lancet in 2020. And first, just to say, the patients were enrolled in this Kaposi sarcoma study from a number of countries, not just in sub-Saharan Africa. You can see Brazil was among those. And it was paclitaxel and HIV treatment, superior to oral etoposide and treatment, and bleomycin and vincristine and the same antiretroviral treatment. And what was important here was that it was a novel paclitaxel dosing regimen that appeared to preserve efficacy and reduce toxicity compared to these other compared to the standard labeling. Now, this slide kind of gives you a sense of what are the key things on this first page of the paper that should remind us what is valuable to consider. We don't talk about value-based care per se in the way that Vishal and Chris and we were having this conversation about the ESMO magnitude of benefit scale and all of that, but the value to the people in the country where these countries where these patients were generously offering their time to be involved. So we've got its relevant disease to the setting, the use of standard drugs, a single primary endpoint, open label, obviously effective safety monitoring should go without saying, but it needs to be said, simplified toxicity reporting, which is something that we're looking at in the US as well, simplification of the whole trials endeavor to make it just more pragmatic for all of us, small p pragmatic, but also pragmatic trials is another area that I think everyone's talking about now. Collaborative and multinational, so that's important. Finally, the senior author was from one of the low and middle income countries, which is critical. And you'd be surprised, well, not if you read the work of the colleagues here in the room, but I would encourage you to take a look at the emerging evidence for how we are perpetuating colonial mindsets and disparities in cancer research as a career by continuing, in some cases, to conduct parachute medicine and parachute research, which has to be a thing of the past. Jumping ahead just for a moment to, I'm not going to show you in any detail, these are complicated slides, but just to say, since I started at the NCI just over a year ago, we put together a small team of colleagues to try to get at this question of what are those core challenges and opportunities to advance high quality, clinically relevant, contextually relevant cancer clinical trials in LMIC. And we've so far done 14 key informant interviews. We had a published request for information, which was another sort of formal mechanism that the NIH uses. We're collecting that information together, and we're using that, both of those findings, which we haven't shared yet, because we're just finishing all the analysis. We're using those findings. Pardon me?
I think that was one of those.
Oh, yes, Vishal, you were one of the key informant. It's supposed to be anonymous. I'm kidding. So, so we've got the key informant interviews, the RFI, and a number of stakeholder engagements. We had one last year in Geneva as part of the World Cancer Congress, and we will be having another one, sort of, unfortunately, they're limited by the room sizes, but we're going to, and you don't want 300 people that can't have a discussion together. So 30 or 40 people will be convening also at ASCO in collaboration with ASCO to gather together some more people who we didn't interview, and getting more and more voices around the table as we go forward, including a global survey that will launch at some point this year, which, you know, it's one of those things that the world needs. Nobody's done it. Probably the Center for Global Health is the group to do it because nobody else will. So that's the kind of project that we like to take on. So stay tuned for that, because we're going to need people to help us pilot the survey. So some of the themes that came out from the key informant interviews in challenges and strategies, the obvious one being the lack of human resource capacity, and not least of which includes, if you're one of 2 oncologists in a setting where you have, for 10 million people, they're not going to have time to do clinical trials. And that's not going to be top of mind for anyone in a setting like that. You need to train more oncologists first and foremost, and oncology nurses and pharmacists and pathologists. And it's amazing how much we forget how important it takes a village to practice oncology well in any setting, doesn't it? Right. So the same could be said for research. The rate limiting step in a lot of places isn't necessarily trained oncologists, but it's often pathology. In any case, we'll get to that soon, and we'll share those findings, and we'll publish the survey when we're ready to do that. Moving to research training at the National Cancer Institute Center for Global Health, we have really kind of 3 buckets. First is to improve global cancer research skills. So this isn't talking about training oncologists to do oncology. That's not really our function, but to train in research and increasing participation of LMIC-based investigators in already existing curricula. And happy to, again, share slides. We can encourage you to look at the website if you don't know about the training opportunities we have. And we also are in a process of identifying key curricular gaps, right? One of the things we're doing as part of the clinical trials programmatic area is to look at training workshops for clinical trials like CREDO, which is really an exemplar, for those of you who don't know, conducted by the Tata Memorial Cancer Center, and the National Cancer Grid of India. And those colleagues have been leading the way to improve, hands-on, week-long, intensive sort of workshop where the faculty to trainee ratio is quite amazing. I think it's 2 to 1. Is it 2 to 1 or 4 to 1? I'm suddenly forgetting. We're looking at that and seeing if, can we maybe help expand the number of people who can attend CREDO, or what about CREDO-like opportunities elsewhere? And I think that's something that at Queen's University, you're also considering in collaboration with colleagues at King's College London and elsewhere around the world, supporting global cancer investigators who are already investigators. And in terms of career development, there's research funds that can go towards career development, and building research environments. And this is where I'm going to jump a bit to, this is the skills page. These are conference grants that are available. The NCI summer curriculum on cancer prevention, we're looking at that again. It's being revised. We also like to connect people with other opportunities that are available elsewhere. So for example, IARC, where I was lucky enough to be a senior visiting scientist for about 8 months before coming on to NCI, they have a fantastic summer school that's now completely virtual. And so even knowing about these other opportunities and connecting people around the world so they're aware of them is one of our roles. The D43 is the last thing I'm going to mention on the training front. This is an institutional training grant awarded to usually a partnership between a U.S. institution, or sometimes more than one, and one or more low and middle income country institutions in a collaborative. Now we have it as a community of practice. I'm going to get my knuckles wrapped for forgetting the name. It's such a cool name. Something Trek. Globe Trek? Okay, if somebody from NCI is on the call, put it in the chat, please. I think it's called Globe Trek. And this is a group, I'll show you a bit of detail about the different awards. And I think this could be really of interest to our Canadian colleagues. Not that Canadian institutions are eligible directly to apply, but to collaborate with folks perhaps in the US. It's possible that in a future round, it will be direct also that LMIC-based investigators can do the application, right? It doesn't have to be necessarily in collaboration with the US. But for now, I think this is also a model that could be emulated. It's something that you might want to discuss with the research funders here at CIHR. So this is an opportunity to provide pre- and postdoctoral training for scientists in the US, but really it's meant for LMIC-based scientists. And it can be any kind of cancer research. It isn't just for clinical research or just for epidemiology. And I'll show you the smattering of really great projects that came out in the last round. It could be short, medium, or long-term training, could lead to just short-term training. It could lead to a certificate or a diploma program that's relevant in that setting, or even a degree. It can be part of somebody's PhD or postdoctoral work. It also helps to facilitate research leadership through mentorship, right, between countries in the so-called global South. And personally, I find that very exciting as an opportunity. So here's the highlights from the 21-22 fiscal year D43 awards. I think you can see that reasonably well. And it's not necessarily just about, we think of low cost, pragmatic behavioral research, although that's incredibly important. But here you see also cancer genomics and genomic data science, bidirectional training to enhance research capacity led by Dr. Tim Rebick, and number 2 there has a big molecular component as well. Got the Vanderbilt Zambia Cancer Research Training Program. These were well-established collaborations prior. I mean, I must say, having looked at these grant applications, wow, there were many that were very high quality and really showed the extent of collaboration between these institutions with not just in spirit, but with publications and in some cases infrastructure that had been built. For example, with specimen biobanks and this kind of thing, but just as an example. You can also see, just wanted to point to one other one that was really, the next one shows you the different topic areas. So here, cancer epidemiology, cancer genetics, bioinformatics, implementation research, oncology nursing. Again, this is an area that is so underfunded, and in my not just my view, I think everybody here would agree, under-recognize the value of oncology nurses in clinical practice and also as research nurses. So I was very happy to see that. Then there's clinical research and mentored opportunities. And these are all the kinds of training opportunities that are available. Planned training of PhD scholars. Yeah, I must say I forget what this 55 plus. I think this is taking the D43 current community would yield this many people on the roads to their PhD. Like it's substantive. This isn't each center has just one person receiving the opportunity to undergo training. Now, I don't have enough time to do nearly enough justice to dissemination of partnerships, which is the other major branch at NCI Center for Global Health. But I do want to say a few things about projects that you might not hear about otherwise, that are not normally considered. If you think about the function of the National Cancer Institute and the, literally billions of dollars that we provide in research grants, you might not think, and the training that we do, of course, in-house in the US in terms of clinical practice and clinical training, you might not think about the opportunities that we try to help with, let's say, to support, such as the International Cancer Control Partnership, the ICCP. And it's something that I wanted to discuss here at Queen's University. I don't know if there's been, I think when I began my involvement with the ICCP, I was probably at the University of Toronto then, because it hadn't started yet when I was here on faculty, but it's just over 10 years old now. And it's really an affiliation of organizations. It's not its own nonprofit or anything like that, but it's a group of, we sometimes call ourselves a coalition of the willing of organizations, including some academic centers, but also the NCI. So we, as the Center for Global Health, host the Secretariat, and we provide funding for that. And our other major partner is the UICC, the Union for International Cancer Control, based in Geneva, that I'm sure anybody involved in global oncology here knows very well. The ICCP provides technical guidance for countries to develop improve and or implement their national cancer plans. And this may sound like, oh, okay, well, so they help them do a report. In fact, I've done a lot of work in the field and seeing how these plans can be, utterly useless if they sit on a shelf, just like any plan in Canada, right? Or incredibly important to help advise the government on strategic priorities, including how best to use your limited resources and dollars towards cancer care and control. So one of the key things that we're working on now, and this also is a segue into the NCI's role as a WHO collaborating center, is to help, at least in one country's situation, to cost their plan, right? So the costing is really essential. Otherwise, it's just a laundry list of things that you'd like to do. So generally speaking, it's like when everything's a priority, nothing's a priority. Well, when something doesn't have a dollar amount attached, it's not going to get any attention. You're not going to get in the room with the Ministry of Finance. And for those of you who've worked in low and middle income country settings, I think like all countries, the Ministry of Health is not exactly high on the totem pole when it comes to, sorry, that's an inappropriate and metaphor nowadays, so we shouldn't say that. The Ministry of Health is low down on the ladder, let's say, compared with the Ministry of Finance, right? So if you, again, we're into the weeds a bit on this maybe, but if you don't do diligence to getting a plan costed, you're not going to get very far in your global cancer control programming. So this last slide here about the ICCP, I would encourage people to look at the portal. You can actually click, I'm just going to toggle back here for a second. National cancer plans, you can look by country, location, and you'd be amazed to see how many plans are live. Some of them are older plans and they need updating, and those tend to be the countries that are now involved with the ICCP to get that technical support. Sometimes the plans are within the NCDs, the non-communicable diseases plan, and sometimes they're standalone. Mostly, we really encourage people to have a standalone cancer plan, usually a national plan. In some countries, like I'm thinking of Canada, also in Nigeria and many countries, it might be a state or a provincial plan, which is fine as well. But the US just announced, we just had our first ever national cancer plan. So you can see here on the chart, I'm not going to go through it in detail, but just to say that a lot of this activity was kind of spawned by the UN high level, the first UN high level summit on political declaration on non-communicable diseases. That was back in 2011. Many of us had already been working in what we now call global oncology for a long time and wondering whether we'd ever get any attention at the UN. And there it came, thanks to the hard work of a lot of people in many countries. This led to the WHO's NCD action plan that we still are building from. There's been Lancet commissions. Here's the one on radiotherapy, a critical commission that was led by Dr. Mary Gospodarovich, who I think is on the line. Who's at the time, she was the president of the UICC. We had one on surgery as well, and other important advances were happening in the realm of global cancer control with the really big redo of the essential medicines list. That's what EML is in 2015. This is when I was at WHO between 2015 and 2016. And then the World Cancer Declaration, all of these things that have been happening. And we think sometimes nothing's happening. We keep having these meetings, but actually a lot is happening. There has been a lot more attention, not enough funding, but there's been a lot more attention and high level coordinated efforts now to advance cancer control and make things more equitable. I think I only have 10 minutes left. So I'm just going to jump to say the number of national cancer plans now on that portal went from 42 countries in 2013 to more than 121. I think, I have the 2023 data, but I don't have it right here. So that's fun to look at. And through the ECHO program, which is, for those of you who don't know what Project ECHO is, it's kind of like it was an earlier version, but now it's really a substantial opportunity to use virtual platforms to connect people with each other. Initially, it was to advance clinical training in the domain of hepatitis C. It's by colleagues at the University of New Mexico. But now it's used also for many, many other things, including national cancer planning. And so the Center for Global Health convenes ICCP ECHOs. And you can see the number of countries now that have been sort of going through our program. as it were. They apply, and we can't kind of provide it for all countries at all times. It has to be a small group, a community, who then share knowledge, best practices between them also, and have found it very useful. And we have some nice qualitative research to show what the impact of these ECHO programs have been. Finally, the Annual Symposium for Global Cancer Research is our flagship conference that the Center for Global Health runs. We made a decision during COVID that it's now completely virtual and will be going forward. This is an equity issue we always are faced with when most of the people who come to the often high-income countries in a global health conference are from high-income countries, and that has to end. So we made the decision to make at least our conference fully virtual. You can see here that we had, let's see, we had a nice smattering of topic areas. We had 659 people from 77 countries attend. And this was the second year we also offered the Early Career Day, Early Career Investigator Day, for, I can't remember how many people came, but it was very well attended. It was completely run by trainees within the National Cancer Institute Center for Global Health, and it's a big hit. So we're going to see what we're going to do going forward. Maybe that, I don't know, I can't tell you, because I don't know. Maybe it'll become a standalone event. But yeah, and finally, the survey of cancer centers. Maybe it's not that interesting for everyone here, but to say that through the auspices of the Center for Global Health, I like to think that we've encouraged cancer centers throughout the US to consider having a global oncology program. And by having this survey and feeding it back to the cancer center directors and publishing it, it kind of is like a bit of a carrot, right? To show what's possible. Because some of the centers in the US have done really remarkable things for many, many years. Long-standing collaborations like University of North Carolina and Malawi program, where our director, Satish Gopal, lived in Malawi for 7 years and worked to enhance cancer care and cancer research in that country. So some are very well developed and some are nascent and some are just starting. But we've seen a big increase in the number of cancer centers now that have global oncology involvement. Now, I want to make sure we have a bit of time for Q&A, and I think I'll leave it there with the Reignited Cancer Moonshot that you've heard about, where we have had a lot of high-profile sort of discussions, including with the US-Africa Summit that happened in the fall, where we published, I wasn't even aware of just how much we were contributing to the work with colleagues from across the African continent, and looking at cancer as a global public health priority and also a global economic priority is probably a win-win way to do things. So thanks very much for your attention. Yeah, so if there's questions, we can look in the chat. I think you have to turn this one on. Yeah.
Thank you very much, Dr. Ginsburg, for this excellent talk. It was very practically useful, very educational, and I think the audience has learned a lot about the opportunities that are available and the role of the NCI in tackling global oncology. But I think it's especially useful for people who are thinking about building collaborations, applying for grants, and the actual tips and tricks of how to start things.
Mm-hmm.
So thank you very much. I learned a lot, and I'm pretty sure that the audience has learned a lot.
Right.
We will be taking some questions. We have some time for questions.
Mm-hmm.
First, let's give priority to people who came here in person. So are there any questions?
Can I click on the chat, or will it?
Yeah.
So
we'll look at it.
But I'm showing the.
yeah, thank you.
Oh, that's nice. Thank
Yeah,
you.
while you're answering the questions, I can look at them. So,
Okay.
Yeah.
Yeah.
Just a quick question. Just going back to the pie chart that you gave, showing in terms of the distribution of funding
Mhm.
between collaborators centered with the US and the individual the PI-led research with the
direct
PI is the direct finding exactly. Is there been an evaluation to see what the differences in impact regarding the research that has been conducted by through direct funding to clients who are in low middle income countries versus the research, which was conducted through collaborative partnerships?
What a great question. I have never been asked that. That's a great question. And I hope everybody online could hear that as well. So the question is, has there been any evaluation to look at the impact of the research that was conducted through direct funding versus the indirect funding that goes to the US collaborators, US PI, usually contact PI, and then there's a subcontract. I think with this particular audience, I can see who's online. Everybody knows what we're talking about when we talk about direct. And yeah, and I don't know that that's been done. Now, it's a pretty small number of research studies, but we could certainly take a look at that. Then how would we measure impact is another question. I mean, that's a tough one. I mean, in the case of implementation research, you could say something like, did this pilot study lead to a transition to scale? Was this scalable, or did something, in clinical trials, you could see, was the trial at least well conducted and published, or that kind of thing. But yeah, something we should think about. Thank you.
And one of the problems that I see with this collaborative global oncology research is that we PIs in high income countries, we get grants and we get protected time for research. But we ask of our colleagues working in LMICs who are already overburdened with patients to devote their time to do those collaborative research for free. Like, we don't allocate funds for their protected time in LMICs where it's much more needed. So I don't know, I just wanted to put this problem into the radar of
Absolutely.
Yeah.
It is on our radar, and I can only speak as on my own behalf to say I would love to see that change. We really do appreciate those of us who are, not just those of us who happen to have been clinician researchers, but wow, and then when you think about the protected time in a setting where there is, like I gave the worst case scenario, you're the only oncologist for 10 million people. I think it's just not very realistic to think that you're going to be able to have protected time without some opportunity to build capabilities for treatment. And that gets into decentralization and the great ideas being put forward through the Canadian experience in GPO, general practitioner oncology programs, and that sort of thing. It's all related to each other, isn't it? Yeah.
And how often does NCI support clinical trials per se, as opposed to clinical research? Like with clinical trials, there is issues of drug funding, and, and whether that trial will lead to registration of the product and so on. So, like clinical trial versus other types of clinical research.
That's a nice plant, Vishal, because there's so much we want to talk about while I'm here on the common sense oncology work. I actually had some portfolio analysis slides on the trial situation. Most of the trials that are funded through NCI are done through the cooperative groups within the US, as you know, I'm sure. And we pride ourselves on funding research that wouldn't otherwise necessarily be funded by industry. And the reality being that industry does fund most trials, and especially is the case, as you yourself, I think, have published on, in low and middle income country settings. So that's kind of putting that aside for a moment. I'm pleased to see, I can't quote off the top of my head, the percentage of research funding that does go to clinical trials elsewhere, but within low and middle income countries, it's tiny. It's really small. And that was one of the sort of challenges that we had before us when I started at NCI, was how can we help advance capacity? It's not just a matter of necessarily funding. It's like what is a cancer research ecosystem? What are the elements that make up such an ecosystem? And what role could all of us who have expertise, skills, or in some cases, potentially funding, provide? So the stakeholder engagement that we're conducting now is part of that exercise. Yeah.
Any other questions or comments? I see one inbox from the
Oh, I'm sorry. Should I click on it here? Sort of informal. No, just, I'm seeing old friends with the people saying nice things. Thank you. Any other questions? And I'm happy to, obviously, people can reach out. I'm easy to find now, Ophira.Ginsburg@nih.gov. I never thought I'd say that, but that's my email. Yeah.
Okay.
Sure.
Thanks so much for your really great talk. So I guess my question is more of a practical one from someone who's in that early stage of my career, who's trying to find partnerships. What do you suggest? That you obviously have a lot of grant opportunities through the NCI, but as you mentioned, a lot of them require a US-based collaborator. From a practical point of view, how would you suggest we go about starting to develop those partnerships? Is there a list of interested people through the NCI to connect with, and what advice do you have in that capacity?
Oh, that's a great question. Yeah, I think personally, one of my favorite, for those of you who know me, one of my favorite things is connecting people, right? And connecting people and connecting groups of people to achieve something really cool that, I might never hear about, but years later you find out something neat happened. I think that's a lot of that is our function as well. And so literally, I mean, anybody on the call or who wants to spread the word about this, if you have questions, you're welcome to email me or any of my colleagues. And we're pretty good at saying, for me, because I'm still so new to NCI, I might then pass it to Mark Parascandola or Paul Perlman or one of my colleagues in the training unit to say, these people are really interested in this area. Wasn't there a program in Botswana, and who was doing that from the US side? And we'll connect you. Yeah.
Okay, thank you very much once again, Dr. Ginsburg, for your excellent talk and for taking the questions and for coming and meeting us in person. And we're looking forward to your talk tomorrow morning as well.
Thank you.
Rounds. And I like
Very different talk.
Yeah. I'd like to request Dr. Khalid Zada, who is our interim head of the department, to give you a vote of thanks and close this global oncology.
No, absolutely. I was just reiterate what you just said, and thank you so much. And looking forward to great collaboration and more visits and more grants from Queens as well. So that's really great collaboration, and looking forward to grand rounds tomorrow. So everyone who tuned in today, please join us tomorrow as well. Thank you again.
Thanks very much.